Okay, let's unpack this. Today we're doing a really critical deep dive into, well, essentially the blueprint for a functioning emergency department. That's the Royal College of Emergency Medicine's guidelines for the provision of emergency medical services, GPEMS, as everyone knows it.
Yeah, and it's crucial, this document, because it really does face reality head on. I mean, the forward itself says EDs have become victims of their own success, basically the system's safety net.
Right.
And that's really compromised the core mission of emergency medicine, hasn't it? That initial fast assessment and stabilization of undifferentiated patients.
Absolutely. And the GPM sort of acknowledges this huge strain and tries to set out a clear definition of what good, sustainable emergency care actually looks like. So our mission today really is to pull out the core standards, the recommendations, and those kind of nuggets of insight that are aimed squarely at improving things for emergency doctors and practitioners, for you listening right now.
And it starts, I think, by defining failure. Defining what that state looks like in numbers. Because, let's be honest, the solution to the biggest problem in EM, it's system-wide, isn't it? It's not just something the ED can fix on its own.
Right. Section 1, then. The existential threat. Crowding and defining capacity. Let's get straight into it. Crowding. GPMS calls it the, quote, single biggest threat to the effective provision of emergency care. We all know it increases morbidity, mortality for patients, but for staff, it's a direct line to moral injury and burnout.
Absolutely. And the key thing here, the really essential takeaway, is the official stance on where the blame lies, if you like. The document is firm. The causes of crowding are in the wider, unscheduled healthcare system, which means the solutions have to be, for the most part, outside the ED.
That's powerful. That gives ED leaders something solid to argue with, doesn't it?
Exactly. Leverage.
So what specifics do the guidelines give? What are the operational standards for the whole hospital system to stop this gridlock?
Well, number one is inpatient capacity, bed occupancy. It has to be around 85%. If the hospital goes much over that, flow just grinds to a halt in the ED. It's almost like a law of physics in hospitals.
A non-negotiable benchmark, then.
Pretty much.
And they stick with the 4-hour target.
They do. They reaffirm its importance, keeping the threshold at 95%, although it is subject to formal review.
Okay. But the really hard-hitting one, the one for public accountability, seems to be this new 12-hour wait standard.
Yes, that's a big one. GPS mandates that no patient should be in an ED for more than 12 hours after they arrive. And critically, this has to be measured and reported publicly.
So it shifts the focus a bit, doesn't it? From just managing flow to actually mitigating harm from delays, putting the responsibility on the whole organization.
Precisely. Organizational detention, essentially.
Okay, so that 12-hour rule tackles internal blockage. What about the pressure coming in? The interface with, say, pre-hospital services, ambulance handovers.
Yeah, another major bottleneck. And it's not just inconvenient, it ties up ambulance crews who should be back out in the community.
So what are the standards there?
They're incredibly clear. Handovers must be done within 60 minutes, maximum.
60 minutes max.
Well, the expectation, the real service level they're aiming for, is much faster. Most should be within 15 minutes, almost all within 30.
That defines what good looks like then.
It does. It sets a clear standard for a functioning interface.
And there's a really vital point about responsibility too, right at the moment the ambulance arrives.
Yes, absolutely crucial this. Responsibility for the patient transfers jointly upon arrival at the department.
Jointly, okay.
So the ED team and the ambulance crew share that responsibility until handover is formally complete. It underlines why you need a proper system to receive patients, get them registered, start assessment, even if you can't physically move them onto a bed straight away. Shared accountability.
Right. Okay. Section 2, sustaining the clinician. Workforce and well-being standards. Here's where it gets really interesting, I think, for practitioners listening. This is about what a sustainable workforce looks like.
Yeah, and finally we get some actual numbers, some quantitative standards for staffing, defensible numbers. For consultants, RCEM says you need at least one WTE whole-time equivalent consultant for every 4,000 annual attendances.
That's the formula.
That's the formula, to maintain governance, quality, supervision.
And they set minimums, too, based on department size.
They do. Clear thresholds. 12 WTE consultants for small EDs. That goes up to 18 to 25 WTE for medium-sized departments, and then right up to 48 WTE for the really big ones.
Those are numbers ED leads can actually take to management meetings.
Exactly, to argue for the posts they need.
And it's not just about numbers. It's capability, too.
Definitely. A consultant has to be available on call 24/7, and crucially, a senior decision maker that's a Tier 4 clinician must be physically present on the shop floor 24/7, 365.
That constant senior presence. Vital for safety, for training. Now, let's touch on the non-medical workforce. There's some very clear, maybe even controversial direction here regarding ACPs and PAs.
Yes, there is. RCEM states it supports the development of the advanced clinical practitioner, the ACP workforce, if it aligns with their curriculum and credentialing. That's quite clear.
But then,
But then, the statement regarding physician associates, or PAs, RCEM currently does not support the development of the PA workforce within emergency medicine.
that's a very definitive stance, isn't it? Especially given the workforce pressures.
It is, and you have to ask why. Why take such a hard line? They're clearly signaling concerns, probably around governance, training scope, supervision, in the context of undifferentiated emergency patients. The guidelines' job is to define best practice, and their current view, stated plainly, is that the PA framework isn't robust enough for EM right now. It's setting a boundary.
Okay, that clarity, controversial or not, gives emergency doctors a clear policy line from their college. Let's pivot to job planning. So important for burnout. GPM sets expectations here too.
Yes. Job plans usually shouldn't exceed 12 PAs, programmed activities, and consultants need a minimum of 2.5 SPAs supporting professional activities, time for admin, teaching, audit, that sort of thing.
Minimum 2.5 SPAs.
Minimum, though they say 3 SPAs is considered best practice.
Right, but let's be honest. 3 SPAs feels like a dream in many places. Is RCM basically saying that anything less than 2.5 is actually contributing to burnout and moral injury?
I think that's exactly the message, yes. They're framing this non-clinical time not as some kind of optional extra, but as essential clinical infrastructure.
Essential.
Yeah. By setting 2.5 as the minimum, they're effectively saying to organizations, if you starve your senior clinicians of this time, you are part of the problem. You're fostering an unsafe working practice.
Wow. Okay, that reframes it completely. Essential efficiency, not a drain.
Precisely. It forces management to see it that way.
They also talk about sustainable careers, don't they? About working patterns later in a career.
Yes, recommending that late night or overnight shifts and being on the on-call rota should reduce or stop altogether from age 55.
Which needs proper long-term workforce planning.
It does. Proactive planning.
And finally, well-being infrastructure. Proper support systems.
Yeah. Every ED must have a dedicated well-being lead with a team who's accessible and proactive. But maybe just as importantly, reflecting the basic realities, the standard also demands access to 247 basic food, hot food, and clearly rostered breaks.
Simple things, but vital.
We've all been there, right? Missing meals, missing breaks in a busy shift. Guaranteeing those fundamentals is key to mitigating that constant grind, that moral injury.
Absolutely. Okay, Section 3, optimizing the patient journey. Flow and specialty integration. So, moving the patient through the department efficiently and safely. What about that first contact, initial assessment?
The standard is pretty strict here. For anyone registered in the ED, initial assessment needs to be done by a registered clinician, properly trained, and it should start within 15 minutes of arrival or registration.
15 minutes, okay.
And this section also tries to standardize the language we use for sorting patients. You know, triage, streaming, rapid assessment and treatment, RAT, often a 2-stage thing.
Right.
They also clarify redirection, sending patients somewhere else, off-site. It's presented as a choice for the patient. If they choose to go elsewhere, there's no formal transfer of care from the ED's perspective.
Okay, clear. Now, moving beyond that initial sort, the guidelines get into dedicated standards for integrated specialty support within the ED. The pharmacy section is really detailed.
It really is, and it has to be, doesn't it? Our patients are getting more complex, multiple conditions, loads of medications. Polypharmacy is rampant.
So what's the staffing recommendation? It seemed very specific.
Incredibly specific. Yeah,
Right.
it reflects the risk. It's 0.1 WTE pharmacist per rhesus bed plus 0.05 WTE pharmacist per majors or high acuity bed.
That's a formula people can actually use. Take it straight to the planning teams.
Absolutely. And the service needs to be there 7 days a week, minimum 5 days, but with definite plans to get to 7.
And the benefits.
Well, twofold. Patient safety, obviously. Better medication management, catching errors, but also economics. The guideline explicitly mentions significant clinical and economic benefits, cost savings, better prescribing quality,
Makes sense.
and they also push for ED pharmacists to become independent prescribers, really using their skills, especially for those complex older patients on lots of drugs.
Right. Finally, in this section, they draw a clear line between observation units and same-day emergency care, SDEC. Different models, different purposes.
Yeah, important distinction. Observation units are defined as short stay, usually under 24 hours, max 48, run by emergency physicians for specific, limited medical needs or treatments.
And the key point for practitioners.
The absolute key point.
Right.
These units must not be used just as a performance management tool, just to shuffle patients out to avoid breaching the 4-hour target. They have to have a clear clinical purpose.
Got it. And SDEC.
SDEC needs to be geographically separate from the main ED. Minimum opening is 12 hours a day, 7 days a week. And the standard recommendation is patients shouldn't be in SDEC for more than 8 hours. It's about providing that urgent care without needing a full hospital admission.
Clear definitions, clear purposes. Good. Section 4, clarity of accountability in complex populations. All right, let's tackle that really thorny issue, the friction point. Clinical responsibility handover. When a referral is made, who actually owns the patient? Emergency doctors need clarity here.
Yeah, this causes so much angst. The document is pretty uncompromising, actually. Once a patient is referred to a specialty, it is that specialty's responsibility to organize the ongoing care. Full stop.
So no bouncing back.
Explicitly, no. It says it is not appropriate to refer the patient back to the emergency medicine service for ongoing management just because, say, a bed isn't immediately available. Declining a referral without sorting out what happens next for the patient is just unacceptable according to these guidelines.
Okay, so when does that responsibility actually transfer?
The standard says specialty teams should assess emergency patients within 30 minutes of the referral being made.
30 minutes.
While the patient is waiting for that review, yes, they remain the ED team's responsibility for immediate care. But once the specialty sees the patient, assesses them, clinical and organizational responsibility transfers to them.
Even if the patient is still physically in the ED?
Yes. The ED team still provides the hands-on care, observations, resuscitation if needed, but the clinical lead for that patient's problem shifts to the accepting specialty.
That's a critical distinction.
Very.
Okay, we've talked a lot about systems, flow, staffing, but EDs are also right at the front line for the most vulnerable people in society. GPEMS addresses inclusion health specifically.
It does, and the statistics they quote are pretty stark. The most deprived 10% of the population have more than twice as many ED attendances as the least deprived 10%.
Nah.
The ED really is that 247 safety net, and the standards reflect this reality.
So what are ED staff required to do?
Well, first, they must fulfill their statutory duty to identify people who are homeless or at risk of becoming homeless.
It's not optional then, it's a legal duty.
It's a legal duty, and they need to try and record up-to-date contact details, which can be incredibly difficult, obviously. And staff need training to recognize that chronic homelessness often signals trimorbidity, that's significant physical health problems, mental health needs, and drug or alcohol issues altogether.
So the ED needs to help with those wider issues.
Provide advice, yes, and referrals where possible. But crucially for practitioners, the discharge plan needs thought. It has to be documented, and it must specifically consider if it's actually feasible for someone experiencing homelessness. Can they realistically get follow-up? Can they isolate if needed? Can they store or take medication? Not just printing a standard letter they can't use.
Thinking about the whole person and their circumstances.
Essential.
Okay, outro then. So wrapping this all up, what does it all mean? The GPEMS really outlines quite a transformative vision for emergency medicine, doesn't it? It feels like a definite shift away from just constantly firefighting crises towards establishing proper, sustainable, system-supported standards, covering workforce, flow, accountability, the whole lot.
I agree. And for you, the emergency doctor or practitioner listening, this document is potentially very powerful. It gives you the leverage, the actual measured standards, the framework you need to argue for a better, safer working environment. It defines what must be met, the standards, and what we should be aiming for, the recommendations.
And it puts a focus on organizational culture too, doesn't it? That mix of shared values and practices. The guideline even suggests that differences in culture often explain performance gaps between hospitals.
Yes, it does. Culture matters.
Which brings us right back to the human cost when the system fails. The document points out that crowding causes harm that's, quote, less visible but well recognized and more important than just long waits. It specifically names moral injury and burnout as key consequences.
The invisible harm.
Exactly. And that leaves us with a final, maybe provocative thought for you to consider. If system failure is defined by crowding, and crowding causes this deep moral injury and burnout, what other metrics should we be demanding? What specific organizational measures, maybe things like staff retention rates, perhaps even publicly reported moral injury scores, should be mandated and made public right alongside the 4-hour target to truly hold the entire system accountable? Accountable not just for patient flow, but for the well-being and sustainability of its most vital resource, its people.